sulfur oxide and carbon monoxide, and it measures and compares the level of those air pollutants between March to May in 2019 to the same period in 2020. And as you can see on the slide, there's a significant decrease in the level of these air pollutants. Now, we do expect this to reflect positively on inflammatory airway diseases. We know that air pollution increases airway hypersensitivity in patients with allergic diseases, and we have reported on this. The action happens at the airway mucosal barrier, and air pollution interferes with the innate immunity and the adaptive immunity, and we expect that with the lockdown, these parameters are going to improve. This came out of Korea in a huge study population, more than 92,000 people, and they have looked at the lockdown effect on the incidence of allergic rhinitis and asthma. And as you can see, the newly diagnosed cases of allergic rhinitis and asthma in 2020 dropped significantly compared to 2019. This is from Italy, patients who have seasonal allergic rhinitis, and they examined the medication used in the year 2020 compared to 2019, and you can see also that there's a significant decrease in consumption and prescription of anti-allergic medications such as systemic antihistamines, topical corticosteroids, and nasal decongestion. And this is from the same report looking at the SNOT-22 quality of life questionnaires and comparing them between the year 2019 and 2020. And as you can see, there's a significant improvement in the score of SNOT-22 in allergic rhinitis patients in 2020 compared to 2019. I would like also to highlight that more allergic rhinitis patients in 2020 felt less frustrated, less irritable, and less sad compared to 2019. Now, we are all primary care physicians or specialists, and we're still seeing patients with rhinitis. So the question becomes, is this COVID-19 or allergic rhinitis? And this shows the classification of rhinitis into 4 categories. Of course, we have the infectious rhinitis, including common cold, COVID-19, and the rhinosinusitis syndromes, such as acute viral and acute bacterial rhinosinusitis, the IgE-mediated inflammation, most notably allergic rhinitis, local allergic rhinitis, the non-IgE mediated inflammation such as NARIS, and the non-inflammatory or neurogenic rhinitis, which is marked by nasal hyperactivity. Most importantly is idiopathic or vasomotor rhinitis. Now, I am showing this because irrespective of the etiology of rhinitis that you have seen in the previous slide, or the ones which are marked on your left side of the slide, irrespective of the etiology, the nose can express only limited number of symptoms. So the nose can either block, it can get runny, it can sneeze, it can itch, it can have a decreased sense of smell. And of course, you get headaches in those cases of rhinosinusitis, and low-grade fever really distinguishes infectious rhinitis from the other rhinitis phenotypes. And I want to include or to discuss a little bit the decreases of sense of smell, because as we know, this is huge in COVID-19. We know that the prevalence of olfactory dysfunction is much higher in COVID-19 as opposed to the general population. So an olfactory dysfunction is a disease pointer in COVID-19, especially if it was associated with a taste dysfunction. And we have reviewed that and looked at the way we do report olfactory dysfunction, whether this is objectively using smell test or whether this is subjectively. And we have really to be careful, because the subjective reporting of olfactory dysfunction really underestimates the true prevalence of olfactory dysfunction when it is reported using objective measures. Now, this is out of Italy, looking at 22 patients with allergic rhinoconjunctivitis who are in the onset of their COVID-19 infection. And what they have done, they have filled a mini rhinitis quality of life questionnaire at the onset of COVID-19 that you can see in orange. And they have asked them also to refill another rhinitis quality of life questionnaire on allergic rhinitis based on their recall of their last episode of allergic rhinitis. And you can clearly see that the patient can distinguish between those two entities. So the quality of life questionnaire really differs significantly between both diseases, and it doesn't take much of clinical judgment for us to distinguish also between those. This is another report from Italy. What they have done, they have asked 43 patients with COVID-19 to fill a SNOT-22 quality of life questionnaire, and they matched them with the 50 patients of allergic rhinitis who also filled SNOT-22. And I would like to highlight also that patients with allergic rhinitis scored less in terms of sadness and feeling of shame than those with COVID-19. And if you compare both SNOT-22, you're going to see also that there is a difference between COVID-19 and allergic rhinitis in terms of SNOT-22 scores. This is from a Euphoria paper, and what they have highlighted is that there are some symptoms which overlap between seasonal allergic rhinoconjunctivitis and COVID-19. Notably, they both share nasal blockage, rhinorrhea, and sneezing, although I would think sneezing is much more important in seasonal allergic rhinoconjunctivitis. Now, itching and conjunctivitis on the left is more prominent in seasonal allergic rhinitis, whereas we're all familiar with the COVID-19 remarkable symptoms of fever, malaise, myalgia, anosmia, or maybe olfactory dysfunction, dry cough, diarrhea, and to that I would probably add taste dysfunction. The management of allergic rhinitis during COVID-19 is quite challenging. Now, all guidelines agree that patients who have mild allergic rhinitis can be managed at home. You can do phone calls, you can do even audio-visual teleconferencing and advise those allergic rhinitis patients. And this practice of medicine remotely is by definition telemedicine. And what I would like to highlight more is the recent application of telemedicine, which is mobile health or the use of digital health application for the management of allergic rhinitis. So we know that there are more than 72 digital applications for allergic rhinitis in the market, and there are several hundreds of those for asthma. But the one I like more is really the Mask Air digital application. This came out from ARIA, and it is easily and freely downloadable on iOS and Android mobile phone. We have launched this recently in Arabia, and it's giving us beautiful results. So I wanted to share this with you. Now, I apologize, this is in Arabic. This is the main menu that you get when you click on the double click on the icon, and from that you get to answer 4 questions. It takes you 12 seconds to do that. And this system uses a VAS scoring system. With the tip of your finger, you can scroll the dot to the right, noting the most bothersome symptoms, or to the left, noting not bothersome at all. So it gives you, it asks you over all allergy symptoms, how do you feel on that with the VAS? And then there's another quick question for rhinitis, another question for conjunctivitis, and then there's one for asthma. Now, what you could do with that is the system places you in one of three areas. The orange, the green zone means that you are well controlled. The one in the middle means you're partially controlled, and the one up means you're poorly controlled. And if it happens that you score three VAS on three different consecutive days, then the system tells you that there's something wrong and you should check your physician with that. And then if you flip your phone, you get a calendar of your symptoms, and it shows you all those domains that you have been asked to fill. It tells you about, your work, your asthma, your conjunctivitis, rhinitis, and overall. This is a beautifully manageable during the COVID-19 pandemic and during lockdown, because you can share this directly with your healthcare professional, and based on that, your physician can prescribe you medications or modify the one that you are previously on. Now, the management of allergic rhinitis during COVID-19 is quite challenging. So as we said, for those patients who have moderate or severe allergic rhinitis and get to visit the hospital, then it is our job to make sure that those patients do not have COVID-19 symptoms. And you go over the symptoms that you see on the left, most importantly, the epidemiological history. And we have also to dig in their history, just make sure that they haven't traveled recently to a place where there's a high prevalence of COVID-19. They have not been in contact with a patient with COVID-19. Now, based on these symptoms, you might decide to transfer your patient to the fever clinic, and you can do all those COVID-19 testing protocols. If you decide that that patient can be referred to the allergy clinic, then we have to make sure that we withhold all those type of treatments, such as skin prick testing, skin endpoint titration, RAS testing, and others like endoscopy. And I'm going to talk about pharmacotherapy and immunotherapy in a second, but I want to highlight also the social distancing that we should implement in our clinic and the personal safety measures. The literature is very rich in those precautions. This is from a APPLICATION-ARIA position paper, and it describes how you should behave and your patient and your nurse in the office. But this one drew my attention. This is on the use of face mask in patients with allergic rhinitis. What they did, they took all those nurses complaining of chronic rhinitis, and those nurses were tested using regular face surgical mask, N92, N95 face mask. And what they have noticed is that these face masks did really decrease the symptom severity. So these masks do not only have a protective role for COVID-19, but also they can actually decrease the severity of your allergic rhinitis symptoms. Now, for asthma, these have been well described. You use GINA guidelines for anti-asthma therapy, should reduce systemic steroids, use metered dose inhalers or powder inhalers, not nebulizers. Now, spirometry, it is a general agreement that it should be stopped or withheld, and in Asia, for example, only if this is a treatment changer, then you can do spirometry. In Asia, immunotherapy, subcutaneous immunotherapy is deferred. If you're talking about maintenance dose, you have to individualize, but with respect to sublingual immunotherapy, there is no interruption. And you're going to see later on that this can differ in different parts of the world. Now, biologics also have been into question. WOW has issued a consensus describing the use of biologics during COVID-19, and it describes all those drawbacks or disadvantages of stopping biologics. This is also important in the upper airway because many patients who have chronic rhinosinusitis with nasal polyps, with or without asthma, are also on biological therapy. And our position has been to continue biological therapy in patients where they are clearly indicated. Now, with the rest of the time, I'm going to go over two clinical cases because things in real life might be different from what you read. And the first case is a 32-year-old health male. This is a patient who has seasonal allergic rhinitis. He has also asthma with it. He has been on good control. He has been on sublingual also immunotherapy, but he stopped it because of, as he claims, COVID-19. Since then, he has been on daily intranasal steroids and occasionally on SABAs. Now, that patient presented to the emergency room with acute episode of seasonal allergic rhinitis because he was in the season, during the season. And after examining him, he had some queries. The first question he asked, does allergic rhinitis or asthma going to predispose me to COVID-19 or its complications? And his queries also were, what should I do with my intranasal steroids, inhalers, and my immunotherapy? So these are legitimate questions. And with respect to the first question, we know that SARS-CoV-2 uses the ACE2 receptor, which is present on the mucosal cells. And for it to fuse with the cell, we need activation of the serine protease to activate the S protein for the fusion to occur. Now, we think that ACE2 receptor is an interferon gamma stimulated gene. So ultimately, diseases which increase or overexpress interferon gamma, such as bacterial tonsillitis, for example, are going to predispose more for COVID-19, whereas diseases which downregulate interferon gamma, such as type 2 inflammatory diseases, of which are allergic rhinitis and type 2 asthma, we think that these are going to protect from COVID-19. Now, remember that these are not quantitated, but it seems logical to assume that. So does allergic rhinitis predispose our patient to COVID-19 complications? This is a series out of Turkey, 125 patients who had COVID-19 and were hospitalized for that. They went retrospectively and looked at those who have or do not have allergic rhinitis, and they looked back at their length of hospital stay. And as you can see, those who had allergic rhinitis did not really differ from those who did not have allergic rhinitis in terms of length of hospitalization. So it seems that having allergic rhinitis does not predispose to more COVID-19 complications. Now, should the patient stop his intranasal steroids? Well, this is another one from also Turkey, looking at COVID-19 patients who have had full recovery from that. The total number of patients were 47, 16 of which were on chronic use of intranasal steroids for more than 16 months, and they have asked both the control and the INS group to record a SNOT-22 quality of life questionnaire, and they looked at their recovery time of olfactory dysfunction and taste dysfunction. And what turned out to be is that those who were on more than 6 months of intranasal steroid scored better on their SNOT-22, and also they had a shorter recovery time of olfactory and taste dysfunction. So based on this epidemiological study, it seems that chronic intranasal steroids improves SNOT-22 and shortens recovery in COVID-19 patients. This is from ARIA, Iyaki statement using the Delphi method. What we have done with that is that we have sent those questionnaires to many KOL across the globe, and using